I think now we have time for a few questions. We'd like to welcome Prof. Crowther again for joining us. And I will start with one question on, the when to restart anticoagulants. This is for Prof. Crowther after a major bleed in different indications. This is a very wide question and maybe by itself worth a 1 hour discussion, but a broad guidance, if you may, please.
Yep, thanks, Hazza. So it's a really important question, and in the long version of my talk, I actually have a couple of slides, one of which says, as soon as a patient is admitted to the hospital with a major bleed, you should include a plan for restarting anticoagulation. And the reason for that is really twofold. The first is most patients with a major bleed can have their anticoagulants restarted because most causes of major bleeds are actually amenable to treatment. It's not normal to have a major bleeding source. And so if it's a bowel cancer, or if it's a duodenal ulcer, or if it's a traumatic injury, in all those circumstances, you can restart anticoagulants. The second is that there's really good quality evidence now that if you take a group of patients who have a major bleed and don't have their anticoagulants restarted, and you take a matched group of patients who have a major bleed and who get their anticoagulants restarted, the group that restarts has a lower risk of death and a lower risk of recurrent thromboembolism, counterbalanced by a small increase in the risk of major hemorrhage. So, the large majority of patients should have their anticoagulants restarted at an appropriate time. So that's the key part of your question. Who should have their anticoagulants restarted? There's some patients who should not. People who have this amyloid angiopathy in their head, that's a cause of recurrent bleeds, a very high risk of recurrent bleeds. And there's a general consensus that people who have that abnormality should not have their anticoagulants restarted. That's a small group of people. Falls are not really a reason. If a person falls every single day, then you should intervene to try to prevent them from falling every day, not stop their anticoagulants. People falling every day suffer fractured hips and fractured arms and other traumatic injuries, which are avoidable by putting in place support mechanisms around to prevent them from falling. The second major question is when, and I would say in general, it's a lot earlier than people want to restart. So Dan Witt, who works in Utah, published a really nice paper at the ASH meeting a couple of years ago, and I would encourage people to look that paper up. His last name is Witt, W-I-T-T, where he looked at the available evidence after gastrointestinal bleeding and said the optimal time to restart after gastrointestinal hemorrhage is probably somewhere between 7 and 14 days. So, it is an hour-long talk all by itself, but to summarize, the large majority of patients can have their anticoagulants restarted, and most of those restarts can occur fairly early once the bleeding source is mitigated.
Thank you, Dr. Crowther. Now to colleagues, I honestly don't see the chat box for questions from audience, but I will ask a question to Prof. Copo, please. There is an old trial on the Italian study on the use of aspirin in ATTP, and it was it was a good number of patients, I think in the 70s, with good outcome, even survival advantage. So are we using a very expensive antiplatelet compared to
Yes, thanks, Azza, for this question. There is a lot to say about aspirin in TTP. So years ago, it had sense to propose aspirin in these patients, as there is these patients have are prone to platelet clumping. So one could it had sense again to propose aspirin in this disease. However, trials showed that basically aspirin was associated with bleeding, and no clear advantage could be shown with the use of aspirin in these patients regarding improvement of organ damage and platelet count recovery. So 20 years ago, now it was stated that aspirin was not indicated frontline in this disease. And with the works of Joel Mock, we understood why aspirin was not so efficient in this disease. It is simply because the pathway by which platelets clump in this disease is the pathway involving VWF and GP1B. And this pathway is not targeted by aspirin. So this is why it doesn't work. On the opposite, caplacizumab is an anti-adhesive agent that is specifically able to block this pathologic interaction. So this is why it works much more than aspirin. And lastly, last years, it was shown that patients who recover an episode of TTP are more exposed to cardiovascular events, even if they completely recovered from their disease. And those patients are more exposed to cardiovascular complications, and they also have a shortened life expectancy because they experience various cardiovascular events. And this is true, especially in those patients who have a mild decreased Adams-Sintin activity. All of that to say that in the end, aspirin could find a role in the management of these patients after patients recovered from the disease to prevent cardiovascular events.
Great. Thank you very, very much. I think we only have time for maybe one or two questions for each. Prof. Crowther, if andexanet is readily available and at affordable costs, what would be the ideal scenario for its use in your judgment?
Yeah, that's an excellent and interesting question. I think I get asked this question a lot, and in Canada it's not available, and I don't foresee it being available because it's too expensive. In the US, it is widely available, and so I get asked this question very frequently by US centers because the full dose is about $50,000 and the half dose is about $25,000, and in most medical systems that's very expensive. So hospitals want to make sure that it's being used sensibly. Ideally, you would have a rapid test that would take minutes to get back, which would say that the person had a DOAC on board before you used andexanet, given its cost. Those things don't exist. So in Europe, as I mentioned in my talk, there is a dipstick that is actually quite reliable, that you can just dip into the person's urine, and if it turns a funny color, then that means it has rivaroxaban or apixaban. If it turns a different color, it means they have dabigatran. If you had that available to you, that would be extremely helpful, because it would tell you, first of all, whether the person had the drug on board, because you know about a quarter of people who say they have taken these drugs don't actually have detectable drug at levels that are clinically important. If you don't have access to that, then I think the obvious case is an intracerebral hemorrhage. A 28-year-old woman has a deep vein thrombosis, gets started on a direct oral anticoagulant, and presents 3 days later with that, because if you can prevent that bleed from progressing, you can reduce the morbidity associated with that bleed, and you'll save money over the person's lifespan. I think probably a limited number of other bleeds, maybe retroperitoneal bleeds where a person is hemodynamically unstable, truly massive GI bleeds where the person is hemodynamically stable. I wouldn't, if it was much cheaper, you would use it a lot, but I think given its cost, you really have to be really careful to make sure you're using it when it's truly going to prevent death, rather than when it might just take a person's bleed from 6 units to 4 units. It really does need to be used in a person in whom you're going to prevent death or significant long-term neurologic morbidity.
Do you think it increased the risk of thrombosis?
Another good question. So when you give andexanet or idarucizumab, people do have thrombosis afterwards, but remember, they're all at increased risk of thrombosis. That's why they're on a blood thinner in the first place. If I had to estimate, I think that idarucizumab does not increase the risk above background. And I think that andexanet probably does increase the risk above background. I'm not particularly worried about that because we showed in our study that was published in the New England Journal that if you get them back on anticoagulants quickly, like your first question, you can completely get rid of that. And secondarily, it actually would be, I think it's advantageous if the andexanet produces a little bit of a prothrombotic burst because you're using it in people with major and life-threatening bleeding, and you want to get their coagulation system revved up. So it probably does produce a small increment in the risk of venous and arterial thromboembolism, but it's completely abrogated by appropriate use of early re-anticoagulation.
Great, thank you very much. There are many questions, and now I could end without finishing, but we'll, for the sake of time and your time, we will move to very quick practical questions to Prof. Coco. The use of SD plasma and the use of cryosupernated plasma versus regular plasma. What is your suggestion?
Yes, the solvent detergent plasma is the widely used in the management of TTP. The cryosupernatant plasma, much less. The rationale for the use of cryosupernatant plasma is that the highest VWF multimers have been removed. So there is a sense for the use of this agent, but basically studies failed to clearly show benefits for this plasma. So it is not routinely used in many countries, and moreover, many countries do not have access to this plasma. So I would say that it is very rarely used in this indication. So the plasma that are typically used in this disease are the solvent detergent plasma and the regular frozen quarantine plasma as well.
Prof. Coco, Prof. Crowther, we are very grateful to your time, and we really appreciate your presence with us. And I think this was a very successful activity. We had tonight 4,000 attendees, and if I may, Ella, if you can move the slides. We had in this annual Saudi Hematology Congress 2021, we had 33,888 registrants. Total attendees 22,997. 75 distinguished speakers, world-renowned authorities, very elegant presentations, and 61 lectures. We are very grateful to all your time and efforts, and we also very greatly appreciative of the support from sponsors, the drug companies. We had our platinum sponsor, Janssen, gold sponsor, AbbVie, Amgen, Astellas, and AstraZeneca, Bristol Myers Squibb, Gilead, Novartis, Sanofi, and Takeda. And all the silver sponsors are shown below: Biologics, Roche, Pfizer. I'm sorry, I cannot see some of them here, but we are very grateful to all the support we got from the audience, the speakers, and the organizers. And thank you all very much. And we're very grateful to you. We hope to see you next year. Bye-bye.
Thank you. Goodbye, Azar. Goodbye, Mark.
Thank you. Congratulations.
Thank you. Thank you very much. Appreciate your time.